to all the PCHS staff. Thank you for joining. And I know all of you have your own scheduled interviews with clients and stuff, but this is an important topic for us. As a South Asian community, we have certain health conditions that affect us more. So this is one of the ways for us to become knowledgeable about these issues, why they happen, how they happen, what role can we play, because prevention is one aspect for PCHS as well. So this will give us some opportunity to learn about why liver disease and the understanding of liver disease is so important. So on behalf of PCHS, thank you for coming. And also thank you to Paula, Natasha, and because this will become really important for us.
Thank you very much. Our first speaker is Dr. Natasha Chandok. Dr. Chandok is a hepatologist with the William Osler Health System and works very closely with UHN and our clinicians here. And Dr. Chandok will cover the topic of liver diseases in the South Asian community in Canada and more broadly. So I'll turn it over now to Dr. Chandok.
Thank you so much, Paula. And I'd like to say a virtual hello to all of the attendees. So today I'm going to be providing a brief overview of liver diseases in South Asians. The objectives of this talk are initially to introduce you to the liver, explain what this miraculous organ does. We'll then discuss common liver diseases, particularly those diseases which affect South Asians. I will then talk to you about ways that we can keep our livers healthy and the types of education and information we need to provide for our patients. And finally, a brief understanding of when transplant is indicated, and I'm sure Dr. Bhatt will expand on that significantly. To begin with, our liver is a maroon-shaped triangular organ. It sits in the right upper part of our abdomen, and it's divided into two lobes. The left lobe is the lobe that's toward the middle of our body, and the right lobe is on the right side of the body. These lobes are divided by something called the falciform ligament. And the liver is an extraordinary organ. It does many things in the body. So it makes bile, which carries waste out of our body. And the bile also assists us in digesting food in our small bowel and absorbing certain nutrients in our small bowel. The liver also makes most of the proteins in our body. It metabolizes fat and converts it into cholesterol, which we can use. It also processes iron and is the second most important site of iron storage in our body. The liver is also instrumental in helping us to recycle hemoglobin and metabolize breakdown products of hemoglobin, such as bilirubin. We can also see this organ as a factory to detoxify. So it will convert nitrogenous wastes into excretable products like urea. It will also clear drugs and metabolizes drugs so that we're able to benefit from medications. The liver also plays an important vital role in detoxifying our body. And finally, the liver plays an instrumental role in our immune system. So the liver manufactures immunoglobulins and immune factors that allow us to fight off infections. Chronic liver diseases are very vast, and part of why I love being a hepatologist is getting to treat many different diseases in many different types of patients. The diseases which affect South Asians most prominently are similar diseases which affect other populations with some exceptions. So today we're going to highlight the diseases in bold: non-alcoholic fatty liver disease, alcoholic liver disease, viral hepatitis B and C. I also want to mention, though I don't emphasize this much in the talk, is that we are unfortunately witnessing an increase in incidence of primary liver cancer. And this has to do with the fact that more and more humans in our population, no matter which ethnic group we belong to, are experiencing liver disease and developing cirrhosis. Genetic diseases and autoimmune diseases, as well as vascular conditions, also affect South Asians. Diseases such as hemochromatosis, which is a common genetic disease, is not something that we see commonly in South Asians, but rather is a disease of Caucasians. So for most of the next few slides, I'm going to focus on giving you a brief overview of the top 3 diseases in this slide. So we'll begin with non-alcoholic fatty liver disease, which is sometimes referred to as NAFLD. Sometimes if you're reading about this disease on a medical website, they may also use an acronym called NASH, which stands for non-alcoholic steatohepatitis, and that refers to a specific stage in the spectrum of NAFLD. This is by far and away the most common liver disease in humans, and the overall prevalence in all humans is about 1 in 5 adults. So it's very, very prevalent. And based on studies that we know out of the South Asian region, the prevalence of this disease may be 2 or even 3-fold higher than some of these population-based studies from North America, pointing to 20%. We also know that the prevalence of non-alcoholic fatty liver disease is rising over time. There are many risk factors and disease associations that we need to emphasize. These include increase in abdominal waist, circumference or centripetal obesity, diabetes, elevated triglycerides, elevated LDL, which is our bad cholesterol, low HDL, which is our good cholesterol, and elevated blood pressure. From research, we have identified that NAFLD is an independent risk factor for cardiovascular disease. The number 1 cause of death in NAFLD patients is actually not cirrhosis, but rather cardiovascular events. So it's very important as clinicians or other allied health professionals that we counsel our patients to try to mitigate any cardiovascular risk factor when we are making a diagnosis of NAFLD. South Asia has a very high prevalence of NAFLD, as we've discussed, and this may be due to a combination of genetic factors, genetic polymorphisms, which have been identified in epigenetic studies, as well as socioeconomic factors. A phenomenon that we do see, not just in South Asians, but other groups of Asians, pertains to something we call the Asian paradox, where we actually start to see fatty liver disease even with normal body mass index. In other words, obesity is not a prerequisite for this disease, and we can commonly see this disease even in lean people. And why South Asia is the epicenter for NAFLD is a subject of ongoing research. Experts believe this may have to do with a sedentary lifestyle, which is emerging as South Asia is increasing in its wealth and affluence amongst its population. This may be related to changes in our exercise behavior that happen with urbanization. It may also be due to poor health awareness and westernization of the diet. Here in Canada, 5.6% of our Canadian population is of South Asian descent. And as you know, if you're working in areas like Scarborough or Brampton, the proportion of the population who is South Asian is significantly higher. So when we're planning for healthcare resources and other resources, we need to bear in mind that this is a very, very big problem in our community, and we do need population-based approaches to try to tackle it. To be frank with you, non-alcoholic fatty liver disease, despite being very common, is not a very well understood disease. So for example, we're not sure why patient A may have fatty liver and not develop scarring, whereas patient B may go on to develop cirrhosis. So there's a lot of unanswered questions. We continue to study it. This disease was first described in the Mayo Clinic in the mid-1980s, and theories around why it occurs is related to a combination of insulin resistance, which is the same phenomenon that causes type 2 diabetes, as well as oxidative injury. If you visit clinicaltrials.gov, you'll be able to look up all the many clinical trials that are occurring in non-alcoholic fatty liver disease, trying to attack these mechanisms. And also, we're desperately trying to search for anti-fibrotic drugs to help our patients. Indeed, this is a complicated disease, a multifactorial disease, where there is a strong interplay between environmental factors and genetic factors. Patients who have any liver disease, be it fatty liver or other liver diseases, may in fact not have any symptoms. And that's why it's very important that screening occur. Symptoms with liver diseases commonly only occur when the diseases are more advanced. The diagnosis of NAFLD is usually made on the basis of an ultrasound showing fat infiltration inside the liver. Sometimes that fatty infiltration will stretch out the size of the liver. So usually the liver would be, say, 12 to 14 centimeters. The liver, with some patients with fatty liver disease, will exceed 16 centimeters. And patients will frequently have elevation in their liver transaminases. The severity of fatty liver disease, and in fact, the severity of any liver disease, can be assessed either through a biopsy, which continues to be a gold standard, but more commonly nowadays, we will rely on non-invasive techniques such as labs, and your clinician may do calculations on different lab parameters to try to estimate degree of fibrosis. We also heavily rely on a high-quality ultrasound. We look for words on the ultrasound report, such as coarseness or nodularity, to give us a sense if a patient has cirrhosis. There are other techniques we can use to measure the liver in a non-invasive way, including FibroScan, which uses sound waves to ascertain the stage of one's disease. So for most patients, we do not need a biopsy to understand the severity of their disease. So any patient with NAFLD, even in the patients who do not have cirrhosis, which are the vast majority, we do need to, as a healthcare team, make sure we are clearly communicating some guidelines. Number one, we want to counsel our patients to avoid heavy alcohol use. And patients should ideally consider avoiding alcohol altogether if they have fatty liver disease. Secondly, we do want to aggressively attack any risk factors or any manifestations of metabolic syndrome, including obesity and diabetes. Thirdly, we do want to provide instructive feedback for our patients to guide them on the importance of exercise, being on a low carbohydrate diet rich in plants and lean sources of protein. Yes, there are some medications that may be helpful in certain patients, but for all intents and purposes, there are presently no medications available on the market to cure non-fatty liver disease or to cure cirrhosis. So we really need to focus on these lifestyle changes. And I often tell my patients that unfortunately, when it comes to health, and I'm sure you'll agree with me, there aren't any shortcuts and there's no substitute for the benefit we receive from a healthy diet and an exercise regimen. I'm now going to switch gears and talk to what I call the fraternal twin of non-alcoholic fatty liver disease, which is alcoholic liver disease. And like NAFLD, this has a spectrum. It can range from bland fat in the liver, which we call alcoholic steatosis, to alcoholic hepatitis, which is a more severe form of liver disease where the patient will exhibit significant inflammatory markers and changes in their blood and on their histopathology. And finally, the end stage, of course, being alcoholic cirrhosis. Alcoholic hepatitis is a clinically significant disease. It will affect 10 to 35% of patients who misuse alcohol. And what we need to bear in mind is alcoholic hepatitis is a major risk factor for alcoholic cirrhosis. So when we encounter a patient with alcoholic hepatitis who is frequently hospitalized if it's severe, we must work our best to try to educate our patients on the importance of lifelong abstainment from alcohol and linkage to an addiction program. Patients with this disease, when it is severe, will exhibit symptoms such as anorexia, jaundice, abdominal pain. They can sometimes develop a fever. In severe cases, they will develop encephalopathy, which has a very broad range of manifestations, but it includes a coma-like state. Patients can develop coagulopathy or thinning of the blood because the liver is no longer manufacturing clotting factors. Patients will look very cachectic. They can develop ascites, which is the fluid accumulation around the abdomen, which occurs with liver failure, as well as sepsis, infections, and variceal bleeding. When patients have severe alcoholic hepatitis, it is actually indistinguishable from severe alcoholic cirrhosis. When we make a diagnosis of alcoholic liver disease, we of course will want to speak with our patients about their alcohol intake, the amount they're taking in, and the longevity of their exposure. Generally, 3 or more units of alcohol in a male or 2 or more units in a female will predispose them to getting alcohol-related liver disease. And emerging research is telling us that even less alcohol than that in a genetically predisposed person can place them at risk for serious liver disease. We know, thank God, that genetics plays a role so that most heavy drinkers do not get cirrhosis. So only about 1 in 10 to 1 in 6 will get cirrhosis. But obviously, we don't know who has the genetic predisposition. And it's very important when we detect a problem to help our patients. On the image to your right, you can see what alcoholic cirrhosis may look like. This patient has dilated veins in his abdomen. We call that appearance caput medusa. The patient has a protuberant abdomen due to significant fluid in the belly. So they may be walking around with 10 to 15 liters of liquid in their abdomen. They will experience fatigue, trouble eating, trouble breathing. And you may also appreciate a loss of muscle mass that you can see in the chest, which happens as part of liver failure. Interestingly, patients in South Asia don't appear to drink more frequently than patients in other parts of the world, including Europeans. So only about 1 in 4 males in South Asia and 1 in 20 females drink alcohol. However, Indians or South Asians who drink appear to drink at similar levels to the rest of the world. And this data, though local to South Asia, has actually been replicated in studies in British Columbia. Now, despite having the same exposure, what we do know quite clearly in research is that South Asians are more likely to develop cirrhosis from alcohol exposure than Caucasians. And this underscores the role that perhaps genetics and other environmental factors may play. How do we manage alcoholic liver disease? So first of all, we want to manage alcohol withdrawal. And I know some of you in the audience work in addictions medicine, and you'll know very well the life-threatening nature of severe alcohol withdrawal. Patients may need to be hospitalized to manage that. We want to then educate our patients on the importance of lifelong avoidance of alcohol and hopefully link them to an addiction program if they are open to that. In the hospital, we would be hydrating them with intravenous fluids. We would also be focusing on optimizing their nutrition. Patients with severe alcoholic liver disease will often come in extremely malnourished. And as we refeed the patients, they can develop something called refeeding syndrome, where they get depleted in many micronutrients and electrolytes, and it can be very dangerous. Very severe cases of alcoholic hepatitis may be also treated with corticosteroids, provided that the patient doesn't have any signs of infection. I'm now going to switch gears to viral hepatitis B and C, and I only have one slide on this because I felt I was able to fit in all of the salient points of these two diseases on one slide. So we'll talk first about hepatitis B. This is a DNA virus, and hepatitis B can cause acute liver failure, which means liver failure and multi-organ failure occurring in a matter of a few weeks due to a severe flare of hepatitis B. Or hepatitis B can cause chronic liver disease or cirrhosis. It can also cause liver cancer, and it is a major risk factor for liver cancer. And finally, it can also lead to extrahepatic diseases. There are 257 million people who have active hepatitis B in the world. This virus is transmitted vertically, so mother to child. It can be transmitted percutaneously through blood or through sexual transmission. Thankfully, here in Canada, as well as most places in the world, every pregnant patient is screened for hepatitis B in her first trimester of pregnancy so that we can actually do our best to prevent maternal fetal transmission. An important point that we need to tell our patients is that hepatitis B is entirely preventable with vaccination and easily treatable with oral medications that have almost no side effects. I'll then talk about hepatitis C. This is a RNA virus. It can cause chronic cirrhosis and chronic liver disease. It can also cause many extrahepatic diseases. The global prevalence of this is about 1%. There are 71 million people in the world with hepatitis C. And I've been told from my colleagues in ID that the seroprevalence in communities like Brampton may be 2 times higher than the national average in Canada, which is about 0.8 to 1%. We do know that there are parts of the world where hepatitis C is very common. The striking example is Egypt, which has the highest prevalence, although they're doing a remarkable job to eradicate the virus very quickly. The Mediterranean basin is also a high prevalence area. In South Asia, from the best we can tell from published studies, the prevalence looks like 1 or 2%, though I have read studies from different communities, for example, in Punjab, where the prevalence was significantly higher than that. And as you know, we may not have robust data from South Asia, given how heterogeneous and large the population is. After exposure to hepatitis C, at least half of patients, if not more, will develop chronic infection. 30% of patients will develop cirrhosis of the liver within 30 years. And when you have hepatitis C, unfortunately, one's overall survival is less than the population who doesn't have hepatitis C. Conversely, if we cure hepatitis C, not only do patients have an improved liver-related outcome, they actually improve their overall survival. And the very important point to mention is that hepatitis C is easily curable with oral medications for just a few weeks. So what I want to emphasize to you and to our patients is that being screened for hepatitis C and being linked to care so that we can manage it does save lives. Liver diseases, as we've alluded to, often have no symptoms. However, when liver diseases are progressive, they may produce constitutional symptoms such as fatigue, anorexia, weight loss. Certain types of diseases, which we call the cholestatic liver diseases, can also produce itching or pruritus. When liver diseases become advanced and patients develop cirrhosis, they may develop portal hypertensive complications. These include variceal bleeding, which is when our patient will vomit blood or see black tarry stool. And this is obviously a medical emergency where our patient would need to go to the nearest emergency department as soon as possible, as they would need immediate treatment. Patients can also develop ascites, which is that fluid accumulation, which we saw a picture of earlier. There are many other complications of this disease. These include hepatorenal syndrome, hepatopulmonary syndrome. This refers to cirrhosis, which leads to kidney failure, or cirrhosis, which leads to shunts occurring in our lungs, and our blood is no longer as oxygenated as it should be. And it can also cause another pulmonary complication, which is called portopulmonary syndrome. And finally, cirrhosis or end-stage liver disease can cause encephalopathy. And encephalopathy refers to neurological disease in the context of cirrhosis. And it can range from day-night reversal to behavior changes to focal neurological deficits, all the way up to extreme coma. This diagram shows us several pictures of the types of problems that our patients may experience. We've already discussed a little bit about the upper left picture where you can see the gentleman with muscle wasting and severe ascites. And I cannot tell you how difficult it is for patients to live with this type of problem. In the upper middle picture, you see someone's palms, and we call this Palmar Erythema, which is the redness of the palms. This relates to a higher level of estrogen in the blood. The liver does so many things in our body, including converting estrogen to testosterone. So with slightly higher levels of estrogen, patients will get dilated vessels in their capillaries of the hands, causing the redness of the hands. The upper right picture is a very fatal complication of cirrhosis called varicyl hemorrhage or varicyl bleeding. you can see large blue columns of veins in the esophagus of the patient. And unfortunately, this patient is bleeding, and patients can very easily die from this complication. So they would need often ICU care, immediate transfusions, immediate intravenous medications to try to help, as well as an urgent endoscopy to try to control this. Now, if we go over to the middle bottom image, you see a man with a helmet. This is a man that unfortunately his bleeding could not be controlled. So he has a helmet on because it's helping to anchor a tube that is going down his throat into his stomach. And the helmet is there because we secure the tube to the helmet. This is called a Blakemore tube, and it's providing traction or tamponading against the varices as a life-threatening complication we're trying to avert. This is what we call a Hail Mary treatment. It doesn't always work. And sometimes we are putting these patients on who have variceal bleeding on very significant life-saving treatments in the ICU. They're often intubated, mechanically ventilated, on inotropes, which are medicines to raise our blood pressure. They may need dialysis. You can imagine the toll this places on the body, and unfortunately, very high risk of death. The image in the lower left is depicting asterixis, which is a neurological manifestation of the encephalopathy. And finally, the image in the bottom right is just to show us the toll this disease places, not just on our patients and their quality of life, but on their caregivers. I'm going to gloss over my next two slides briefly because I know Dr. Bhatt is going to provide us with an overview of transplant. But very briefly, in the community, my job is to identify patients who may have a survival benefit to transplant and try to link them to the transplant team as soon as they have a survival benefit for this surgery. In Canada, over 600 transplants are done. Most transplants are from deceased donors. This is a major surgery, and in very well-selected patients, it's an exceptionally successful surgery. And I would dare say that here in Canada, outcomes are the best that you can find in the world. So I think our transplant colleagues do a remarkable job. As you know, if one is waiting for a deceased donor, the wait time can be an issue. And sadly, many patients will pass away while waiting for a transplant simply because there may not be enough deceased organs that are available. And that's why discussing with patients other options for transplant, including live donation, is so important, because live donation would essentially eliminate the factor of the wait time. I want to close with prevention, and I'm sure you'll agree with me, but I think the way our healthcare system is set up is we sadly do a poor job with preventative medicine in our population. But we really need to try our best to try to generate preventative medicine within our population, especially as it comes to diseases like obesity, diabetes, liver disease, etc. So hopefully we can work together to educate our population on what a healthy diet looks like, what a healthy exercise regimen should be. We want to encourage our colleagues in primary medicine to screen our patients for liver diseases, since when they are caught early, we may have an opportunity to intervene and potentially prevent liver cirrhosis or liver cancer down the road. We also want to work together to provide early education to our teens on the hazards of alcohol misuse. We need to work at a provincial level to start putting labels on alcoholic beverages to help our population. And we want to improve access to the services you provide. And I thank all of you for the hard work you do in the community. And finally, we want to improve awareness of liver transplantation, awareness of surgeries like live donation, and improve access to transplant for our patients. So I thank you so much for your time, and I will hand over to Dr. Bhatt.
Thank you very much, Dr. Chandock. And Dr. Bhatt will be sharing her slides in just a minute. If anyone has questions, please keep them until the end, and we'll try to address all of them.
Okay, well, good afternoon, everyone. So it's my pleasure to speak to you about liver transplantation today. And so my name is Mamatha, and I'm a hepatologist and clinician scientist at the Ajmera Transplant Program in Toronto. And I'm also within the Division of Gastroenterology and Hepatology at the University of Toronto. And so the outline of my presentation is going to be on liver transplantation, living donor liver transplantation, and long-term outcomes. And I'd like to thank Dr. Chandock for that wonderful overview of liver disease, chronic liver disease, as well as particular facts pertinent to the South Asian population. Actually, I learned some new facts, which, regarding the South Asian prevalence of liver disease and genetic predisposition, which I think are very important for the community to be aware of as well. So I'll start off just with some Canadian statistics overall. So chronic liver disease affects more than 3 million Canadians, and it's projected to rise in the coming years with the increasing incidence of non-alcoholic fatty liver disease alongside the parallel epidemics of diabetes and obesity. And this is in fact true worldwide. So with the adoption of more sedentary lifestyles and calorie-rich diets, certainly this is a phenomenon that we're seeing globally. So the death rate for chronic liver disease has reached over 10 deaths per 100,000 in 2021, and Canada had an estimated 5,000 deaths due to liver disease last year. So what happens when the liver fails? So chronic liver disease really evolves over many years for the most part, so over 20 to 30 years. And so when you have chronic liver disease, basically what's happening is there's an insult to the liver, but the immune system basically reacts against that insult and is trying to control that insult. So if it's fatty liver disease or alcohol or viral infection, basically the immune system is trying to fight that. And in that sort of ongoing crossfire, basically the liver suffers as a bystander. And so there's triggering of inflammation, but also triggering of a scar response. And so this is what happens, say, when it's injured, then there's a scar response to that. But then the interesting thing about the liver is that it also has this capacity to heal itself. So the liver is very unique as an organ. It has the unique ability to regenerate, whereas no other organ, so the kidneys, the lungs, the heart, none of these other organs are able to regenerate. If you think about the other organs, like say the skin or the gut, those actually have the capacity to regenerate. But the liver is the one solid organ that has this wonderful capacity to regenerate. So what happens is over time, very quietly, there may be some chronic liver disease happening, but at the same time, there is some degree of regenerative response to allow for some healing. However, over time, over many years, an individual can develop cirrhosis due to a certain chronic liver disease. So it's kind of an end pathway, the same common pathway that ultimately can result in cirrhosis and ultimately end-stage liver disease and even liver cancer. So by virtue of that constant turnover of the cells, there's the possibility to accumulate mutations and ultimately liver cancer. And so liver cancer, for the most part, develops in the setting of chronic liver disease and cirrhosis in over 90% of patients. And ultimately, that can result in death. So what is the role of liver transplantation in all of this? So if you think about the liver, as Dr. Chandock mentioned, it is integral to the metabolic reactions that are happening in our body. It's integral to all those, say, conversion of sugar into fat, into protein, like lots of metabolic reactions that are happening, but also the production of clotting factors, the production of bilirubin, the production of hormone binding proteins. So there's this regulation, production of protein that is integral to maintenance of blood pressure. So there's lots of different functions. So what happens when cirrhosis develops? So over time, as cirrhosis gets worse, then the liver cells are less able to function. So there's the factory aspect, so a decreased production of protein and detoxification. And then there's also portal hypertension. So I'll talk a bit about the MEL sodium score, which is what we use to kind of quantify and reflect the degree of liver disease or severity of liver dysfunction. So when someone has cirrhosis of the liver, as I mentioned, there is this worsening synthetic function, okay, the ability to produce proteins. And we, based on previous research, there was this development of the MEL sodium score that now is used to prioritize patients on the waiting list for transplant. And that result is a number between 6 and 40 and is predicated on these 4 parameters: the creatinine, the bilirubin, the INR, and the. And if someone is on dialysis as well, so that also adds a certain number of points. And then based on the score that is obtained, one can quantify the likely risk of mortality in the upcoming 3 months. And so a score of 33 would be associated with a 3-month mortality of 53%. And so normally we consider liver transplantation, particularly when the MEL sodium score is 15, but then if they have certain other complications, which I'll talk to you about, and those are debilitating, then one would consider liver transplant referral even earlier. So it's case by case if the score is between 10 and 15. And we use this MEL sodium score routinely in practice to prioritize patients on the wait list. And just to give you an idea, the average MEL sodium score at which patients will start attracting a deceased donor organ offer in Ontario is between 28 and 30. And that will be dependent also on the blood group, the body habitus of the patient. So most deceased donor organs will come from men. And so the reality is that, say, a smaller person, thin, smaller person, a woman will have less ability to attract such a deceased donor organ offer. And that has implications for mortality on the waiting list. So in terms of decompensated cirrhosis and also portal hypertension, so Dr. Chandock spoke about this already, so I'll gloss over this, but these are basically the manifestations that you will see in patients with decompensated cirrhosis or worsened liver disease, including the encephalopathy. So liver transplantation involves replacement of the diseased liver with a normal liver, either from a deceased donor or a living donor. And here in this picture, you can see the liver that has been anastomosed or connected to the recipient's vessels as well as bile duct system. And so you can see that here, there is this anastomosis that has been created. And so liver transplant procedure lasts on average 4 to 6 hours, plus or minus, depending on the degree of complexity. And there are certain risks associated with this procedure. I think that's beyond the scope of this talk, but basically we offer this when it's pretty clear that the benefits of the procedure would outweigh the risks. One very important thing to note is that there is no machine that can replace the liver's highly complex functions. So you are aware of dialysis, which is offered to patients with end-stage kidney disease. And similarly for the heart or the lungs, there are machines that can help in terms of keeping someone alive until a transplant. Unfortunately, in liver transplant, so in patients with end-stage liver disease or liver failure, we unfortunately don't have any machine that can really replace those complex functions and keep people alive until transplant. So this has very important implications in terms of, say, when referrals are made to our program or when we're taking care of patients on the waiting list, we're highly aware of this, that medical care is of the utmost importance to keep people alive until transplant. So there's clearly a need for further donors. So in 2020, there were 545 liver transplants, and in 2021, about 526 in Canada, adult liver transplants. And so overall, we know that organ supply cannot meet the increasing demand. So the average MEL sodium at which patients are transplanted in Ontario, as I mentioned, is quite high. And so this means that there's 25 to 30% mortality or dropout So say patients can become too sick for a transplant, unfortunately. And so I talked about liver transplantation generally earlier, but there are a few different types of donors. So there's brain dead organ donors, cardiac death organ donors, and then living donors. And basically here you have a picture of living donor liver transplantation. So I'll talk a bit more about that in subsequent slides. But basically, this is, something that is offered at certain centers in Canada. So 2 out of 7 liver transplant centers in Canada offer this as a procedure. And basically, this involves a healthy person below the age of 60 being able to donate up to 60 to 70% of their liver. And so we evaluate such individuals who step forward. Normally, they're family members or close friends who are stepping forward. Once someone is waitlisted, put on the liver transplant waitlist, then such individuals may step forward, fill out the evaluation form, and undergo an evaluation to be a living donor. And the beauty of the liver, which again is a very unique organ because of this. So the beauty of the liver is that once you resect even up to 60 to 70% from an individual, the liver does rapidly regenerate to a normal volume by 12 weeks after the surgery. And so both in the donor as well as the recipient, by 12 weeks after the surgery, there is this regrowth to a normal volume. And this, again, it's the only solid organ that is capable of doing this. So really a miraculous ability of this organ to be able to regenerate to such normal volume. There are certain risks to the donor as well that we certainly explain to them. But, for example, in Toronto, we've done over 1,000 living donor liver transplants and have been very fortunate to have excellent experience without any major complications or deaths. And so the advantage of having access to living donor liver transplantation is that patients who don't have a very high MELD score on the waiting list are able to have access to liver transplantation. So regardless of their demographic characteristics or indications, and certainly there's a decreased risk of dropout or death having access to living donor liver transplantation. And the nice thing is that they're transplanted when they're less sick. So say from experience, I can tell you people who have a very high MELD score going into transplant, unfortunately, they have a much higher risk of complications after the transplant and take much longer to recover from the surgery. They have to go to rehabilitation to work on their physiotherapy and all of this. So certainly living donor liver transplantation gives access to liver transplantation at an earlier time point in the disease course, such that you have better longer term outcomes, and there's also better quality organ. So as I mentioned, these are individuals who are below the age of 60. It's a voluntary choice, and donors really gain a deep satisfaction from having saved a life. And so this is, again, you can see this in this picture, basically that they've donated this large portion of the liver. And of course, what we need to ensure during their evaluation is that whatever the donor is left with as a portion of liver is sufficient to maintain their life as well. So certainly one has to ensure that the portion of liver remaining is sufficient to allow for regrowth, because if there's too less of that, then the liver is unable to regrow. And the liver also knows when to stop growing. So by 12 weeks after the surgery, the beauty of this liver is that it actually knows when to stop growing in relation to the body size of either the donor or the recipient. So in terms of survival after liver transplantation, there have been dramatic improvements in terms of short-term survival. So 1-year survival rates have dramatically improved in the last 3 decades, from 65% 1-year survival to 95% 1-year survival over time. And these are the rates we quote to patients. So 80% 5-year survival, 70% 10-year survival. And so you can see that. However, if we look at actually long-term survival beyond a year, there is much work to be done with respect to this, because survival beyond a year has remained a bit stagnant. And so, we are offering transplant to more and more complicated patients these days. So in recent years, there are more and more people who are a bit older, diabetic, have chronic kidney disease. So there's all these, say comorbidities, as we call them, so other conditions. So we really need to have a thorough evaluation of patients to ensure that they would benefit from transplant as opposed to the risks. Now, if we look beyond a year after transplant, you must keep in mind that patients will come in with their certain degree of comorbidities, but then they're also exposed to anti-rejection medications lifelong to protect the liver from being rejected. So the liver is coming from someone else. So basically the immune system recognizes that as a foreign body. And so they need to take immunosuppression or anti-rejection medications lifelong. Most people do. So the liver is very unique again. So in certain very careful studies, a certain proportion, so up to 20% have been able to get off of immunosuppression. But for the most part, in practice, recipients do need to take anti-rejection medications lifelong. Now, by virtue of taking such anti-rejection medications, patients will have a higher risk of cancer, because as soon as you suppress the immune system, you're also suppressing the ability of the immune system to recognize abnormal cells, such as cancer cells or infection, like bacteria. So they have a higher risk of cancer, they have a higher risk of infection, higher risk of diabetes and associated heart disease. So if you look at the 10-year risk of cardiovascular disease and mortality, it's 2 to 3 times higher in liver transplant recipients as compared to an age and sex matched general population. So really the anti-rejection medication is an important factor in contributing to this risk. So for each recipient in the long term, we always have to balance the benefits of anti-rejection medication with the risk of complications. And particularly in the South Asian population, as you know, diabetes, heart disease, these are important, risk factors for mortality. I think all of us have relatives with diabetes and heart disease, etc. So, so it's a very, heavy burden in the South Asian patient population. And so with liver transplantation and exposure to immunosuppression, you're particularly accelerating that risk and aggravating that risk. So nonetheless, liver transplantation is obviously life-saving, and I think we have a lot of work to do in terms of long-term complications. And certainly the research I do is focused on fatty liver disease and metabolic disease after transplant, as well as the higher risk of cancer and liver cancer recurrence in these patients. So certainly we have a lot of work to do, but nonetheless, overall liver transplantation is a life-saving operation. And I hope both Dr. Chandock and I have convinced you that the liver is an integral organ performing multiple functions essential to life. Different causes of chronic liver disease. Cirrhosis develops over decades. Fatty liver disease is currently the most chronic liver disease in Canada. Liver cancer develops in the setting of cirrhosis most often. There's no dialysis that exists to replace the complex functions of the liver, and liver transplantation is life-saving for end-stage liver disease, as well as certain other indications such as liver cancer. So thank you for your attention. And these are some of the websites that are helpful in terms of providing more information and kind of consolidating what I've presented to you, what we've presented to you today. And I'd like to acknowledge my colleague, Dr. Tsian, the UHN Living Donor Program, as well as the Canadian Liver Foundation for some of the information that I presented to you today. Thank you.
Paula, I just want to ask the doctor about drug use. We have recently have an increased number of young South Asian men addicted to drugs rather than to alcohol. Is there a risk for liver failure or other complications as a result of illegal drugs. So these are cocaine, crystal meth, and those heavy duty
Yes.
drugs, heroin and stuff. So if you can comment, because we have an addiction program, both in the alcohol one and also the drug one, that will be helpful as well.
Yeah. Shall I answer that, Natasha, or did you want to? Okay, sure. Okay. So certainly, in terms of acute liver failure, so Tylenol overdose is the most common cause of fulminant liver failure, as we call it, and that can occur in the setting of ongoing alcoholic liver disease. And this is the most common cause of, say, liver failure, acute liver failure in the Western Hemisphere. And so in younger individuals, it's most commonly associated with, say, a suicide attempt or, a history of depression, repeated such episodes. Now, coming to illicit drug use, well, and then I should also comment for Tylenol-associated liver failure, for the most part, so in 70% of cases, they will recover with treatment, with medical treatment, but then the other 30% either will pass away or need a liver transplant. Now, coming to illicit drugs, so certainly cocaine is associated with what we call vasoconstriction, so like a constriction of the blood supply to the liver, and it can cause fulminant liver failure as well. So we can see, say, due to that lack of blood supply, liver failure. And say, in terms of liver transplantation, the use of such illicit drugs and associated liver failure is a contraindication to liver transplantation. So if, say, they had other conditions leading to decompensated liver disease, then individuals would need to be free of such illicit drugs and be committed to remaining free of such illicit drugs for at least 6 months before being considered. Any other comments, Natasha? Do you want to add on to that?
Yeah, I think also we'd have a concern about the patient's risk for infection, be it HIV, hepatitis C, which someone can get more than once. And so we really would want to focus on mental health care, linking them to an addiction program, and hopefully rescreening them for, particularly infectious diseases and other diseases to try to help the patient.
So in the South Asian community, there is a lot of discussion within the community around cleansing of the liver, either through some kind of a treatment or drinking water or a combination of many different things, or just eating fruit and nothing else. Does that actually help in terms of actually cleansing the liver, or is it just one of those kind of things that the community just kind of anecdotally participates?
Are you referring to, say, Ayurvedic medications?
Yeah.
Do you want to talk about that, Natasha?
Sure. Thank you. So I would just maybe start off by saying that liver cleansing is not really a phenomenon that is going to make a difference. But what does make a difference is regular exercise and a healthy diet. There are obviously a lot of foods and natural foods that we can incorporate in our diet, and that is the best strategy to, quote unquote, keep our liver clean.
Yeah.
But we cannot expect, say, we go on a week of a juicing diet, that we're going to somehow rid our body of, fibrosis and toxins and fat. But I would just encourage the patient to live healthy. And we're all human. We all have social events, and we may indulge in food and sometimes have alcohol at times. For the most part, for the average patient, that's not a bad thing. But I just tell patients, 80% of the time, on the day-to-day basis, eat lots of different colored vegetables, incorporate fruits, eat lean sources of protein. And specific to the South Asian diet, try to reduce your intake of foods made of flour, grain, or sugar. So this would be rice, roti, bread, cereal. These are carbohydrates. And when we eat those, they turn into sugar in our blood. And that's what's driving fatty liver and liver scarring and inflammation. So I just tell people day to day, please eat healthy. I know many patients ask about lemon and turmeric capsules and other things. So please eat those foods, but there's no need to buy any specific supplement. There are supplements that patients take from different cultures, be it in Chinese medicine or with Ayurvedic medicine. And we do, on not infrequent occasions, see liver toxicity from these agents. Yeah. We must remember that they are not studied by Health Canada. They are not studied in a clinical trial for us to know the ingredients, for us to know as clinicians whether these ingredients are safe. So what I would tell people again is I wish there were shortcuts to good health and good liver health, but we have to live healthy, use common sense. But liver cleansing really has no merit, unfortunately. I wish it was that simple.
And I think, the important thing is also lifestyle. So, certainly, too much ghee, frying, sweets, all of this is not going to lead to, and a sedentary lifestyle with no exercise certainly is going to be deleterious to health, right? So gaining weight in the setting of such a lifestyle. So I think, especially with the, say, availability of calorie-rich food, one needs to be particularly cautious in this setting. And I know in India as well, or South Asia in general, the rates of obesity have been increasing with that kind of sedentary lifestyle and ready access to calorie-rich food. And the other thing is, I guess, with Ayurvedic medicines, certain like the elixirs can contain some alcohol. So it's important to check exactly the ingredients that they put on their list. But I think overall, what I would, say is that such elixirs are not recommended by us because we have seen cases of liver toxicity, and we have seen cases of even alcoholic liver disease related to the use of such medications where there is some degree of alcohol content. So I think, the message we give to patients is basically to stay away from such herbal medications or elixirs where it's not, obvious what the ingredients are, and there is a certain risk of liver toxicity. So basically just adhering to a good lifestyle, healthy lifestyle is the best thing that people can do to maintain the health of their liver.
Thank you very much. Perhaps we can just take one more question. There's a question that came in. Is it true that alcohol-induced liver failure patients are put at the bottom of the wait list for liver transplant?
That's not correct, actually. In Canada, at liver transplant programs, basically, and particularly in Toronto, I can speak to you about the Toronto and Ontario experience. Anyone who's referred with alcoholic liver disease and even a recent history of alcohol consumption can be referred, and then we will review their history, and there are certain criteria that we use to determine, first of all, whether they have medical indications for transplant and whether they have any contraindications. And so, for example, if someone has been repeatedly told in the past that they have liver disease due to alcohol intake, and so they come into hospital with worsening liver failure and they're referred to us, then what we would say is that at that point that they're not a candidate for transplant, but would need to engage in relapse prevention therapy, demonstrate commitment to alcohol abstinence, and then be re-referred to our program. However, if this is a first presentation of liver disease or say complications related to their significant alcohol consumption, then the story might be different. So it's really on a case-by-case basis. So we have transplanted patients where there has not been, say, a long-standing period of abstinence, but there are, say, mitigating factors. So they have excellent social support. They are very committed to long-term abstinence from alcohol. And this was really the first time that they had been told that they had, medical complications related to alcohol consumption. So what this demands really is a very strong psychiatric assessment, social work assessment. So there's various facets, given that alcoholic liver disease is not just a medical condition, but there's also the psychiatric assessment that is critical to the assessments of candidates for liver transplantation. So one cannot have, say, active psychiatric disease and also be considered for liver transplantation. If they have an active, say, addiction that needs to be treated, then it needs to be treated first before liver transplantation can be contemplated.
Thank you very much for that very comprehensive response. And thank you all for joining today. It sounds like there may be additional opportunities for Drs. Chandock and Bhatt to join you and do further education within the South Asian community via your organization. We will be following up with Baldev and others in your organization to determine if there is an interest in additional education sessions. And I will also forward some resources, some information about living donation that may be useful to share with patients that you're seeing in clinic. So thank you very much for joining. The recording of this session will be available very shortly. I'd like to thank Drs. Chandock and Bhatt for doing such a great presentation, and thank you all for your attention. Have a great day.
Okay. Bye-bye, everyone. Thank you.
Thanks, everyone. Thank you to Paula and Dr. Bhatt. Bye-bye.
Okay. Bye-bye.